Welcome to PG Pulse, Press Ganey's podcast on all things healthcare, tech, and human experience. In this podcast, we'll be joined by some of the best and brightest minds in the industry to discuss challenges, share insights, and innovate the future of healthcare. Thanks for tuning in. We hope you enjoy the conversation.
I'm Dr. Tejal Gandhi, Chief Safety and Transformation Officer at Press Ganey. Today, I'm joined by two incredible leaders from the Mayo Clinic who are helping define what always-on safety looks like in practice. Dr. Subashnie Devkaran, Chair of Quality and Value, and Dr. Sean Dowdy, Chief Value Officer. At Press Ganey, we talk about zero harm 24/7 as a leadership commitment. Not a goal we check off, not a priority, but a core value and a promise upheld every role, every shift, every day. Mayo Clinic is one of the organizations that really is bringing this to life, and so I want to thank you for both joining me today. And I want to start off with your thoughts on what zero harm 24/7 means in practice. We often say zero harm is the only acceptable goal. That has been controversial at times. I talk about it as an aspirational goal, and reaching for it requires constancy and clarity. So at the Mayo Clinic, Subashnie, I'll start with you. How do you define high reliability in a system as large, complex, and dynamic as the Mayo Clinic?
It's such a wonderful opportunity really to share our insights at Mayo Clinic. So thank you for having us today. When we think about high reliability at Mayo Clinic, we think about it as reliable excellence because we're in constant pursuit of getting better every single day and getting better to the extent that we're in a category of one. But at the same time, it requires us to constantly adapt, constantly to renew our vision, our operations, and challenge the status quo. And so when we think about high reliability, I often say it's resilience, but with purpose, because we are grounded in our values, and our primary value of which is the needs of the patient come first. And when we think about that, that is a primary embedding mechanism of our culture. And it informs the decisions that we make every single day. Not only that, but it creates the ability of translating high reliability into operations. And like you said, zero harm sounds aspirational. And we need to challenge ourselves to say, how does zero harm become not just aspirational, it actually becomes operational? And so I don't know, Sean, do you want to add anything about our perspective of high reliability?
Yeah, so I think Mayo Clinic is known for our 3 academic medical centers in Minnesota, Florida, and Arizona. But what many people don't know is we actually have 19 hospitals. We're not a holding company, we're a healthcare system. And so high reliability across the system means that regardless of which door you walk into, regardless of what state it is, if it's Wisconsin or Florida, we want to make sure that we're providing the same highly reliable, safe, effective, and respectful care, whether or not you're getting a simple screening procedure or getting a complex operation. So that's what high reliability means to me, is really across all of our hospitals, you're getting the same excellent care.
That's interesting because I say zero harm 24/7, but it's 24/7 and at every location.
That's right.
That you have, right? You don't want that variation across locations.
Mm-hmm.
And I really liked what you said about your everyday trying to get better, because I think that's another important concept. When we talk about HRO, often it was high reliability organizations, and we always like to turn that into a verb of high reliability organizing, like it's a constant journey and constant actions that you have to take. Sean, over to you for this one. So I mentioned safety as a core value rather than a priority. And what do you think changes when leaders treat safety as that core value versus a priority that might change over time?
Yeah, I'd answer that in reverse. So, for over 150 years, Mayo Clinic's primary value has been the needs of the patient come first. So all 85,000 employees know that, and they see that every day. So if we stray from that core value, then we failed on our contract with the patient. So I would say safety isn't something we do, it's the thing that we do. And I think everybody understands that.
It's great.
I love the question because when safety is a priority, it competes. It competes with other priorities. And what happens when priorities are at risk of financial downfall or other competing priorities? It becomes negotiable. But when it's a core value, it's non-negotiable. But it's also the mechanism of decision-making, right? It's what informs decision-making on a day-to-day basis. So we should be thinking about safety as a value. Because as we talk about culture and safety, words don't teach, right? It's the behaviors that continuously incent that virtuous cycle of reliability.
Yeah, well, let's move into behaviors a bit. And, when I've been thinking about this too, in safety, we started out a lot around process and technology, but we have to think about people plus process plus technology. And, in Dr. Tom Lee's book, Social Capital in Healthcare, he highlights a simple Mayo norm. If someone pages or texts you, you respond without questions, no matter your role. So thinking about those people behaviors, right? Subashnie, I'll start with you. Why do small behaviors like responsiveness, like what he mentions in the book, why does that matter so much for safety and reliability?
Well, I think you and I feel the same way, is that safety is not battered. It exists in the spaces between people, and it occurs due to the strong relationships. And Tom Lee talks about that with great eloquence in his book. And when we think about culture and social norms and social capital, it comes down to those micro behaviors that create psychological safety. And things like responsiveness at Mayo Clinic, answering a page actually translates to answering an email, answering a text. But what you do is you flatten the hierarchy and you send a powerful message that you matter, you're important. If you have a need, I am here. And that type of environment generates this team-based philosophy and that collective accountability. That we're not just here for myself, but we are collectively here to support each other as we care to the best of our ability for the patient's families.
Well, and you said the needs of the patient come first, but this is highlighting the needs of your colleagues and your teammates as well, and how critical those are in building that teamwork, which we know teamwork is a critical key driver of safety outcomes, of engagement, all of those important outcomes.
We try to translate to the patient.
Exactly.
And I love it that Tom uses that example, because it's something that we should probably talk about more, but don't. But, even when I was a resident, this has been a tradition for a long time. It's kind of been an unspoken tradition, but you can be rounding, you could be in the middle of a conversation with somebody, your pager goes off, you stop, you answer the pager. That's just what everybody does. And when I was a resident, I knew that I could contact anybody in the organization if I needed help with something. So that gets to the bridging that Tom was talking about. So there's the horizontal bridging, so I could reach out to another surgical service if I needed help with something. And then there's the vertical bridging as well. So I can page a consultant, an attending within my department, within another department if I needed to. There better be a good reason for that. But you can do that as an intern if you need to, and it's accepted. So I think it really sets a very good example of teamwork, and it flattens the hierarchy pretty significantly as well.
Well, I was just thinking about that. I was thinking about flattening of hierarchy, psychological safety, that you can do this, and that connection to the bridging and bonding. It just creates such a powerful culture. And I love that you talked about even when you were a resident, because it shows the culture of the Mayo Clinic, but also I always talk about when these behaviors become habit. When you can't imagine a time when it wasn't like that. Now, I can imagine in my training that was not the case, that you could just page anybody. So it wasn't an ingrained habit, but it sounds like it is just so ingrained in the habit and culture. So, Sean, you talked about that as a resident, you were able to do that, et cetera. How do leaders model these kinds of behaviors so they can really hold these behaviors or ensure they're occurring at every level of the organization and occurring 24/7? What are the things that leaders are doing?
Well, I think everyone is a leader. So, everybody understands that Tejal Gandhi is a leader at our organization. They know Subashnie leaders, but everyone needs to embrace their role as a leader. And that's particularly true for physicians. I think physicians oftentimes don't understand the impact that they have on those around them. So, people are watching us, and when we're not acknowledged for the 99% we get right, we're acknowledged for the 1% we get wrong. So we really have to be careful with our words and our actions, because what we do is really amplified all around us. So I think that an acknowledgement of our role as leaders is extremely important, not only for creating the institutional culture, but also for the microculture. So if you lead a team of 5 or a team of 500, you can still have an incredible impact on those around you. So it's, respectful interactions. It's not just talking about assuming benign intent. It's demonstrating the assumption of benign intent. And those things you have to do that every minute of every day.
So zero harm 24/7, I'll keep coming back to that theme. It's the people part that we've just been talking about, but then certainly it's processes and systems. And Subashnie, you and I have talked a lot about how do we design our systems and use technology in our systems, et cetera. So as you think about zero harm 24/7, one of the commitments there is trying to get upstream and proactive as opposed to reactive, and understanding where there's risk before harm, et cetera. So how are you thinking about process and technology or systems to really make that happen, making risk visible before harm occurs?
Thank you for that question, Tejal. Oh, my goodness. This is such an important conversation. I loved your talk this week when you talked about how we measure safety, and that we're offering measuring people who fall into the ice and the thickness of the ice, right? And so the criticality around our advancement and safety has to be, can we not only go from reactive to proactive, but can we get to predictive? And Sean and I are very excited because we do have an initiative at Mayo called the Mayo Clinic Safety Platform. And what we are doing is really leveraging agentic AI to support our safety leaders in the organization. We are so delighted that we get thousands of safety event reports, many of them, of course, being near misses. But we are limited in the bandwidth to analyze them, to leverage the lessons learned, and more importantly, to close the loop, not just give the feedback, but then say, what actions, what can we do differently so we can prevent the risk? So we've started, leveraging the historical data that we've collected over many years around safety events. We are now using agentic AI to release the administrative burden by having an agent that actually generates triaging of high harm events. So we focus on high risk and the right type of event at the right time, ensuring the right type of action. But then that's just the iceberg, right? The next layer of that is we're going to use AI to generate knowledge around pattern recognition. So patterns of events that have occurred over time that could give us insights into system failures. And then in addition to that, we already have a large language model full where it's going to surface potential harm events before they occur, leveraging insights from the electronic medical record. And so these would be unreported events. And eventually the vision is that if we can understand the etiology of a safety event, then why doesn't each patient have a safety risk score, right? You think about a patient, a complex patient, many of these patients we see at Mayo Clinic who have a catheter in, who have a central line in, might have fragile skin, nutritionally compromised. We all know pressure injury, colitis, collapsing, but we don't see it at the individual level. And I believe once we can do that, then we can truly prevent harm at the individual level, and it gives us a better chance of not just being predictive, but being prescriptive. Today, we have nurse bundles that are standardized for every patient. Which patient is standard? Why not have an individualized bundle per patient based on their risk score and safety?
Well, and it's prescriptive and preventative, right?
Correct.
So
preventative part
that's
is
the
critical piece.
that is the key. You know, there was a really interesting. All right, I'm going off script. No, there was a really interesting study at Brigham and Women's where they created that kind of safety score at the patient level, and they actually shared it with patients and families.
Yes.
And they told patients and families, what questions should you be asking? What actions should you be even taking along with the team? And it was very well received. And there had been concerns that patients would be scared by having this information. And of course, that was not the case. And patients really felt empowered by having this information. So I think, you know, in our future state, and we'll get to this later about partnering with patients and families, I think that information is key for the clinical team and also for the patients and families. So that's hopefully where we're going to get to. But, you know, another important piece of what you were talking about, and one of the things we're really focusing on as well, is using technology to improve the work of people working in safety. And for years, we've really struggled with kind of being swamped with the data and struggling to turn the data into insights, into action. And I think we're getting to the point with the tools that we're all working to build where we can, you know, kind of reduce that burden of the data and drive more effective actions and really have our teams focusing on the improvement as opposed to just, you know, what should I be doing? And so I think it's a really exciting time for people working in safety because it's been a 25-year struggle to really get to that action piece. You know, and in addition to the technology, and Sean, I'll ask you this question, you know, we talk about other systems and processes to try to get upstream, things like huddles and rounding and so forth. Are there other process type things, non-technology, or maybe facilitated sometimes by technology, but other processes that you all are implementing or have implemented at Mayo?
Yeah, in the past, we've just relied on hiring the right people to do the right thing, and that's worked, but it only gets us so far, right? I mean, you can't get to the next level just relying on people to do a good job, and despite their best intentions. So you do need better processes. I think you do need technology. Recently, we did start doing enterprise-wide huddles, so we have a tiered safety huddle system that was frankly very difficult to get going, but we've managed to do that, and it's actually working very well. The other thing that we've added to this is digital visual management boards. So we have almost 200 of these boards across the enterprise at the different nursing units. So as individualized quality metrics specific for that unit. And there's also the ability to escalate concerns that they have, especially safety concerns. So many of those concerns can be handled locally, but if they can't, they can be escalated. So something like that impacts supply chain, for instance, you know, a local nurse manager may have no idea how to address that. That's something that may need to be escalated, you know, multiple times until it gets addressed. Mm-hmm. So one of the things we've really concentrated over the last year is being more sensitive to those concerns that they have locally. Because it can be really demoralizing if you're looking at the same broken chair every day, or something mundane like that can have a pretty negative impact on the local culture.
Yeah, and it ties into sort of the sensitivity to operations, the deference to expertise, getting at that frontline input, et cetera. You know, I think high reliability sometimes gets oversimplified to be about standardization and only standardization, or, you know, doing the same thing every day, et cetera. But there's so much built into high reliability that is about this sort of, you know, constant listening, constant learning and improvement, and making sure that you're hearing about the issues that are going on and getting proactive, et cetera, that, you know, these processes really help to reinforce.
Mm-hmm. I think standardizations really should be designed to be right 80% of the time. You probably can't standardize much above that. Maybe you could push the limit a little bit, but there's got to be some individualization there. In the operating room at Mayo Clinic, we used to have a saying that we do it the same way every time, and that's great for routine procedures because you can be incredibly efficient. You do it the same way, you get really good at it. But On the other hand, if we're doing it the same way every time, we're probably doing it wrong. So you really have to have some space for individualization, whether you're talking about processes or procedures.
Yeah, I have a list of things I wish I had known when I was running safety back in the day, and that is one of the things because, as equity has come to the forefront, and I've been talking a lot about safety and equity and how we have to bring the equity lens. And one of the pieces there that I think, I didn't realize certainly is when you think about standardization, you can standardize, but then sometimes certain groups are left behind. And so you may have to customize to make sure everyone is achieving that same outcome. And so I think your point is really well taken that, there may be times when you can totally standardize, but a lot of the times you have to have that buffer. But then what's key is understanding what's happening in that 20%. And, learning from that as well. There might be things you can improve over time related to that, et cetera, but not having it be just this rote thing.
Yeah.
So I think that's a really important point. Okay, let's talk about engaging patients and families, especially with your core value around patients. And, the Mayo Clinic has been intentional about bringing patients and families into safety and quality conversations. I learned recently about some really interesting work that you've been doing around focus groups. So, Subashnie, you want to tell us about how you're using patient and family focus groups to better understand safety risks and priorities?
Yes, really, really excellent question. Traditionally, when we've engaged patients, in healthcare, it was often met with a lot of trepidation. What would they say? Would they understand? Do they have the health literacy to really understand the risks of healthcare? What we have done at Mayo is that we do have a robust patient family advisory council. It's a large community of patients, and we utilize this incredible community to test different design ideas, various initiatives, perceptions around technology that we're bringing into the organization that have a safety implication. And then very lately, we've assessed their perceptions of safety. Because as you know, HCAPS is planning to include it, but it isn't included today. And what we learned was quite interesting. When a patient comes in, of course, the physical environment is an important component of their perception of safety. They look at cleanliness as a cue, a visual cue. They look at lack of clutter, organization, and etc. But that's the physical environment. But what was more interesting, and it won't surprise us, is they could assess the team dynamics with great accuracy. And that for them was really critical in their perception of safety. Is how do team members communicate with each other? How do they communicate with the patient, the concordance of the communication that they have with the patient, and then gaps in communication. And as you know, patients feel unsafe when they feel confused, when they feel that they are uncertain, or have questions that are not answered. So those were quite interesting. But more importantly, teamwork is one of our values. And Mayo Clinic is a team-based, multi-specialty practice. And so it just reminded us that teamwork is such an important cornerstone of everything when it comes to patient experience, patient safety, and quality.
Well, and it really reinforces the patients are so perceptive about things that really matter. Mm-hmm. We have so much data, as I mentioned, that teamwork is correlated with outcomes. CMS added teamwork questions to the CAP survey because it was coming up so often as a driver. So patients really do understand the importance and value of that. And I think this is also why the CMS Patient Safety Structural Measure has Domain 5 around engaging patients and families, because it is really critical. Organizations have struggled to do this. So I think that is, pushing all of us to think about this idea of engaging, getting input, and really co-designing with our patients and families. And, back when I was CEO of the National Patient Safety Foundation, we had done a report about transparency with patients as being critical to advancing safety, transparency within organizations and with patients. And I was very interested in work that is going on about a patient-facing website that you've created to help people better understand quality ratings. And so, Sean, over to you about the website you've created and really, why Mayo has invested in this and wanted to really accelerate transparency with our patients.
Yeah, that's exactly right. Yeah, last fall we launched healthlocator.org, so that's the website that helps patients identify a hospital close to them that might fit their needs. So this provides information on over 5,000 hospitals. The reason we put this together was really twofold. Number one, we felt that even though Mayo Clinic has done very well over the last couple decades with public rankings and ratings, we felt that there were some methodologic issues that we can improve on. One example, for instance, is about 85% of hospitals are 300 beds or less, and they simply can't compete with large hospitals with the current methodology. So it's sort of unfair for those hospitals, and it's not helpful for patients if they don't live near a large academic medical center. Which leads to the second reason for doing this, which is to improve transparency, as you said. And you can't have transparency without improving accessibility. So all of this data is available. Okay, you could say that we're being transparent already because it's already out there. But even Subashnie and I can't even make any sense out of this. We need a whole team to help us make sense out of that data. So what chance does a patient have? And so when we designed this website, it was really important to us that we were fulfilling the wants and the needs of patients. And so we had a lot of input from patients about what should be in the website, how it should be presented to help them make the best choices for their healthcare.
Well, I think, first of all, co-designing with our patients and families is a critical aspect, and then giving them information to help them make decisions. I mean, to your point, I've had to think about, recommending places for healthcare for family members. And it is, even for folks like us who are embedded in quality and safety, it is no easy task. So I really applaud the initiative and the effort that I know it takes to create this site and try to advance this for the industry, really.
Even, last year at this conference, your CEO talked about how his wife had gotten appendicitis. This is a CEO of a healthcare organization. And went to a hospital. They're out of town, and she got substandard care. She was dismissed, and then came back a couple hours later and had an operation in another hospital. So that's just one example of somebody who even has incredible familiarity with healthcare was unable to find a hospital when he was out of town to meet their needs.
One of the things you would like about HealthLocator is that we have developed a reliable excellence measure, and as Sean was mentioning, many of the current systems that we have in place for rankings and ratings disadvantage the small hospitals because they clearly don't have the volume. The reliable excellence measure that we developed actually went through a scientific process through random weighting of various measures that exist today with CMS and others. And what we were able to do was even the smaller hospitals, as long as they consistently performed with excellence over time, they could meet the reliable excellence threshold. And that is about 9% of hospitals in the United States have a reliable excellence indicator based on those random measure weights.
Well, that's so critical, especially to your point, Sean. Many people don't have access to the large places, so we need to understand the quality that's getting delivered at some of those smaller organizations, and for them not to feel like they can't rely on this data. This gives them, something that they can strive to improve as well. So both of your roles include value and connect safety, quality, cost, and experience. So, and we've talked about safety as a core value, et cetera, but certainly the realities of healthcare, we do have to think about cost as well. So how does high reliability support and not compete with value and affordability? That's a hard question, so I'll start with you, Subashnie.
We talked earlier about, safety not being additive, right? And when we think about high reliability, the same applies. High reliability is not additive. High reliability is really the way we stop paying for failure. When we think about value, think about the penalties that we incur as healthcare organizations when we are paying for the safety events that have occurred. So when we think about the word value, at Mayo Clinic, we have a value equation, which won't surprise you. It's, quality outcomes as well as the experience, and of course the absence of safety events, or the absence of harm or cost. We used to have a title called affordability, and we actually relinquished that because we felt that affordability was really driving more to the bottom line. And we felt that value was more enhancement around the numerator, which is quality, safety, and experience. So at Mayo, we actually do have a Mayo Clinic Value Index that is a composite of key metrics around quality, safety, and experience. And it is the measure that is our North Star for quality, but it is also the measure that gets reported upward. And our ability to ensure that we're prioritizing those key initiatives at Mayo Clinic results in the outcome of less penalty, a reduction in cost, elimination of waste, improvement in productivity, and of course, better value for our patients.
And so, Sean, are there specific safety investments that you can think of that have really paid off in terms of that equation? And, I've talked a lot about, impacts of safety, for example, on workforce engagement and retention, which is, a hard dollar, et cetera. So, where have you seen some of the safety investments really helping that value equation?
I think you had mentioned workforce resilience as well, and I'd want to focus on that because I think that's really important, and it's gotten a lot of attention in recent years, workforce resilience and wellness, and I'm glad there's been some attention on that. But I think one thing we've missed is to acknowledge how unique healthcare providers are. We're different than other businesses, nurses in particular, but physicians as well. We're humanistic, we're empathic, we're altruistic. And this is at a time when we have lost some of those qualities. We're less about community and more about individuals. We've kind of lost our common moral code in many ways. And so I think the healthcare industry has a role to play here. And when we talk about some of the work we do in safety, we can't miss the fact that this really is inspiring to our workforce because they are mission-driven. And many of the exceptional outcomes that we have, we'd like to change this and hardwire some of this, but a lot of the exceptional outcomes we get are because of discretionary effort. Mm-hmm. And so if a workforce feels that the whole organization is invested in improving quality, safety, and experience, that's what's important to them. So if they feel like that they're supported in that, I think you can imagine that people are going to spend more discretionary effort doing the main thing, which is the needs of the patients come first. So if we really focus on quality, safety, and experience, I do think that is really inspiring for our patients. That helps with some of that workforce resilience because they're working towards something that's larger than themselves. So the more we make the main thing, I think the more we can help with some of that resilience.
I agree. And our data shows when you think about key drivers of what keeps somebody in an organization, feeling like they are in an organization that delivers high quality, safe care is a really critical driver for people. And so this work, to your point, really inspires the whole organization and is our reason for existing.
That's why we're here in the first place. And you have great data showing that relationship between retention and what organization is not wanting to retain more of their staff.
Exactly.
That relationship between retention and quality and safety and experience as well, but safety in particular.
And, let's talk a little about why this is hard.
Sometimes
sometimes I use the Sisyphus analogy of like pushing the boulder up the hill. This is hard work. Subashnie, what has been harder than maybe people might think, or that you even have thought over the years? What has been harder about sustaining or advancing high reliability over time?
Yeah, I would say specifically at Mayo, we have just truly an incredible legacy. The Mayo brothers set expectations that care needs to be collaborative, team-based. We need to be patient-centered, means that the patient comes first, and relentlessly excellent. And that legacy is no longer a guarantee. Through high reliability practices, we have to be able to renew that legacy every single day. And I find that incredibly difficult. Our legacy is no guarantee of success in the future. In fact, if we think that our past successes are going to beget future successes, that in itself is a flaw. And so the enormous pressure on us as leaders at Mayo Clinic to continuously amplify the legacy, but even build for the future, is the most difficult part of high reliability. And the ability to constantly challenge ourselves and say, yes, we might be in a category as the one based on how we're measured. That's not good enough. Because if we're not constantly renewing that challenge every single day, we are not creating a future where our peers, our patients that come to us is going to benefit. Well, that pressure is enormous because it requires us to really look at our thoughts and all, look at our systems continuously and say, is that good enough? No, good enough. We can't settle for good enough. Is that best in class?
Well, and it's a journey, as we said. We're constantly needing to improve and revisit and get better. So that is hard that you never get to the end. Sean, what about you? What's been harder than you expected or have experienced?
I think in terms of trade-offs, one of the difficult things is, as Subashnie said, talking about this expectation of excellence, which gets to zero harm. And I agree with you. I think that is an aspirational goal, but if we don't have aspirations, we'll never get there. We may not get to zero harm in our lifetime, but we're working towards achieving that maybe in the future, when our careers are over. So on the one hand, we have this expectation of achieving perfection. On the other hand, we have to create a safe space for people to report things when they don't go, perfectly.
Right.
And those two things seem at odds with each other because I think there's this inherent want to sort of bury some of that, maybe not bring it up to the surface because, have I done something wrong? This is less than perfection. But really they feed on each other. They're synergistic. So we can't get perfection without recognizing, as you said, warts and all. I think that's a really difficult thing for some people to understand. And then also if you integrate into that the concept of preventable and unpreventable harm, there's some harm that's not preventable. And sometimes the distinction between those two is somewhat gray, so that confuses things as well. But I just think so much of this comes down to psychological safety and the ability to talk to each other and help each other.
Totally agree. I think it's the psychological safety is so key, and the feeling that the organization is listening when you do report these things and that things are improving, because that will drive the reporting for sure, as opposed to some of the other reactions that sometimes can get experienced. And I think, one of the things that I would talk about a lot too is, we're striving for zero harm, but we don't expect humans to be perfect. Mm-hmm. To err is human. And so
infallibility is impossible.
So, that because when we were training, it was you as the doctor need to be perfect. And if you weren't, it was like an individual failing. And so I've had many conversations with physicians to say, like, you will make a mistake. You are human. And it's sort of this gasp in the room kind of thing. And it's like, but that's why we have to understand when those things happen, design systems, et cetera. But that's been a hard shift, I think, for the industry. All right, I'm going to wrap up with a final question here, a tough one. If you could change one thing across healthcare tomorrow to accelerate progress, what would it be? Subashnie.
Oh, gosh. Well, I think throughout the conversation we had today, we recognized the critical importance of systems. So if I could change one thing, I would want us to shift our focus from expecting our incredibly talented staff, healthcare providers, to be heroes. We rely on heroics every single day to prevent harm. And we should start thinking about embedding harm-free designs into everything we do. And that includes the new AI algorithms that are coming out, the new technology. We really need to have a mechanism where the systems are truly designed so that harm is not just preventable, harm is eliminated. And the component of, standardization, as you mentioned, versus adaptability, we need to be able to empower our staff to operate in the most complex adaptive system on the planet, which is healthcare. And the tools that we design for them should give them the space to do that, to be their best human that they can be. And so, as you said, system design over clinical heroics is what I would recommend.
All right. Love that. And Sean, one thing you would change?
Well, it's a big thing, but as long as you're asking, I think one of the greatest failings of our healthcare system is the inability to translate what we already know into practice. And that's true for quality, safety, experience. It's true for how we deliver medical care as well. So we just don't have a good way of learning on the fly, of ingesting information from even our own institution and implementing that into patient care in less than 8 to 15 years, depending on the study. So I think every institution has some kind of method of doing that. It's just a question of how well developed it is. And there are very few organizations who cooperate with other organizations to achieve this as well. So if we can create, and you've probably heard of this, the concept of a learning health system, where we ingest external information, we create new data internally, we analyze that, and then implement that on the fly. If we can do that, then we've got this flywheel of continuous improvement. And, in a meeting like this, we learn incredible things about what other organizations are doing, big and small, and we just don't have a great way of implementing that quickly. So I think this concept of learning health system is really, really important. It's too much to talk about today, but I think, if listeners could familiarize themselves with the National Academy of Medicine Learning Health System Initiative, we'd really like to create something that's not just within organizations, but cross-cutting across organizations as well.
Well, and that ties into this transparency conversation as well. One of the things in that report I mentioned from back in the day was transparency across organizations. And I think, so I love this idea, because we can't just be learning within, we have to learn across the industry. And I mean, one of the things that we're trying to do with the Press Ganey Patient Safety Organization is say, we need to be learning about safety from our other health systems around the country and not have the same events happening everywhere. And so even if you solve it or someone else solves it, but then if we don't know about it, then we are continuously having the same harms occurring. So I think this concept of learning across organizations is so important if we're going to really accelerate our progress. So thank you both for those challenges to the industry. So today's conversation really reinforces that zero harm 24/7 is not necessarily about achieving perfection, but it's about clarity, trust, shared responsibility, and disciplined systems sustained over time. And I really want to thank you, Subashnie and Sean, for joining us and sharing how Mayo Clinic is advancing safety and reliability through a whole range of activities, and want to thank our listeners for joining us as well.
Thank you.
That's a wrap. Thank you for joining us today, and special thanks to our guests for sharing their time and insights. Stay tuned for our next episode, which will be released soon. In the meantime, visit our website, where you'll find more information on the human experience and a lot more.